Hi everyone, today I am going to discuss about appendicular lump or appendicular mass. We can also call it as a periappendiceal phlegmon. First of all, what is meant by a phlegmon? So whenever there is any inflammatory process going on in our body, the structures which are affected by the inflammation and the surrounding structures, they try to localize a seal of the inflammatory process which forms a soft tissue mass. So phlegmon is nothing but a inflammatory soft tissue mass. So periappendiceal phlegmon is nothing but the phlegmon that is formed around the appendix. So whenever there is an acute attack of appendicitis, the structures which are surrounding the inflamed appendix, they try to localize the inflammatory process within the appendix, which further forms a mass or a phlegmon around the appendix. This is called as periappendiceal phlegmon. So periappendiceal phlegmon is nothing but a soft tissue inflammatory swelling or a mass. Soft tissue inflammatory swelling or a mass in and around the appendix. This is called as periappendiceal phlegmon. Next, we will see about what are the possible sequelae or outcomes of acute appendicitis. If a patient develops acute appendicitis, what could be the further possible complications the patient can develop? First of all, it could resolve completely without any complications, or it can produce a recurrent attack of acute appendicitis after a period of time. If there is any wall of necrosis, it can produce appendicular perforation. So second sequelae can be appendicular perforation. Third one, it could lead on to formation of an appendicular lump or a mass. Appendicular lump or a mass. Fourth one, if there is any suppurative process going on within the appendix, it can lead to appendicular abscess formation. So these are the possible localized sequelae or complications if a patient develops acute appendicitis. If there is widespread of infections, it can lead to peritonitis, septicemia or septic shock. At last, due to inflammatory process going on, there could be adhesion formation between the appendix and the bowel, so which can lead on to development of intestinal obstruction at a later stage. Now we will see about the appendicular mass proper. Incidence of appendicular mass is about 2 to 10%. That is 2 to 10% of the appendicitis patients can develop appendicular mass or a lump. It usually develops on the 3rd to 5th day after an acute attack of appendicitis. So the structures surrounding the inflamed appendix, such as your greater omentum, terminal ileum, cecum, so all these surrounding structures, they try to localize or seal off the inflammatory process which is going on within the appendix, so which finally results in the formation of appendicular mass or a lump. So appendicular mass or lump formation is usually a protective mechanism by our body to prevent further spread of the infection. Appendicular mass or a lump formation is a protective mechanism. So what are the clinical features of a appendicular mass patient? So initially patient will be having features of acute appendicitis, such as your fever, vomiting, abdominal pain, plus patient will be having a mass in the right iliac fossa. So what are the per-abdomen findings of appendicular mass? Appendicular mass is usually a firm tender mass in the right iliac fossa which has got a smooth surface. with well defined borders. But you have to remember one thing, that during an acute episode of acute appendicitis, due to generalized or localized guarding, we could not be able to make out the borders of the mass clearly. Once the guarding and all settles down, we will be able to make out the borders of the mass very clearly. And mass does not move with respiration, as it has got no connection or with the diaphragm directly or indirectly. Class the on percussion, a resonant note will be heard. So, what are the structures which form the appendicular mass? First of all, it is where inflamed appendix. Next, your terminal ileum, greater momentum, and then where cecum, mediated cecum, and then parietal peritoneum. So, all these structures will form the appendicular mass. First of all, is where inflamed appendix. Second is your terminal ileum. Third is your edematous cecum. Fourth is your greater momentum. Fifth is parietal peritoneum. So all these structures will clump together to form the appendicular mass or the lump. So next we will see about the investigations in appendicular mass. First of all, we will be doing routine blood investigations like a complete blood count, in which total leukocyte count is very much important. Next, we will be doing radiological investigations like ultrasound abdomen pelvis. Ultrasound abdomen pelvis is usually the initial radiological investigation of choice in the case of appendicular mass or a lump. In what way ultrasound abdomen pelvis is useful? Ultrasound abdomen pelvis helps us to have a rough estimate about the appendicular lump or a mass. By using ultrasound probe pressure and graded compressions, we will be able to have the dimensions of the appendicular lump or the mass, so which helps us in the follow-up of these patients. So by serially monitoring the appendicular mass patients with ultrasound abdomen and pelvis, we'll be able to find out whether these patients are responding to our conservative management or not. So if you see here, it is an ultrasound abdomen and pelvis of a appendicular mass patients, which shows serial decrease in the size of the appendicular mass or the lump over a period of time. So which helps us in monitoring of these patients. Third investigation is where CT abdomen and pelvis. So CT abdomen and pelvis is much more sensitive than ultrasound abdomen and pelvis, particularly to rule out appendicular perforation or an abscess formation. So particularly to rule out appendicular perforation or abscess, CT abdomen and pelvis is more superior than your ultrasound abdomen and pelvis. Next, we will see about management of the appendicular mass. So there are various management options available for a appendicular mass. Traditionally, we were following the conservative management, which is called by the name ochsner sherren regimen, which was followed since 1901 when Ochsner introduced this regimen. After successful conservative management, we will be doing internal appendicectomy after a period of 6 to 8 weeks. But there has been controversies among the surgeons whether to do internal appendicectomy or not. Some surgeons do not prefer following internal appendicectomy after successful conservative management. With the advent of laparoscopy, even immediate laparoscopic appendicectomy is one of safe management options available for appendicular mass patients. So these are the management options available for appendicular mass patients. We'll be seeing one by one what are the pros and cons of these procedures. So first of all, we will see about the conservative management, that is your ochsner sherren regimen. 1901, Ochsner introduced this regimen. Since then, we are following this traditional conservative management. So what are the components of ochsner sherren regimen? There are totally 5 components in ochsner sherren regimen. First of all is your fluid resuscitation. Patient will be dehydrated, so we have to resuscitate the patient with IV fluids, and we have to correct the electrolyte imbalances. Next component, second component is your you should keep the patient nil per oral. If at all needed, if there is severe vomiting, we can put nasogastric aspiration also. And for pain, third component is for pain you have to give adequate analgesics. Preferred one is NSAIDs like aceclofenac or diclofenac, or even you can use opioids like pethidine or pentazocine. Fourth component is to control infection we have to give parenteral antibiotics. The preferred antibiotic is usually your third generation cephalosporins. For anaerobic control we have to add metronidazole. Alternative antibiotic options available are we can use ampicillin or gentamicin along with metronidazole. Fifth component is very much important component, which is nothing but monitoring of the vitals and the symptoms. This component is very much important because based on this component only we are going to decide whether to continue or discontinue the conservative management. So in this component, what all things should be monitored? We have to monitor the pulse rate and temperature. Every 4th hourly we have to monitor these things, and we have to monitor blood pressure, and we have to keep an IO chart maintained, and we have to monitor the symptoms of the patient. If the patient develops any fever, abdominal pain, these things should be monitored, and we have to monitor the size of the lump. At the time of admission, we have to mark the size of the borders of the lump, and we have to measure the size. So with the serial monitoring of the size, we will be able to look if the lump size is increasing or decreasing. So if the lump sizes keep on decreasing, it is one of the indication for stopping the conservative management and take up the patient for emergent or immediate surgery. So these are the things you should be monitored in a case if a patient is kept on conservative management. So this is a diagrammatic representation of ochsner sherren regimen. So we'll be giving IV fluids, nasogastric aspiration, and we will be giving IV antibiotics, and we have to monitor the symptoms like pulse rate, temperature, and lump size. Usually 90% of the patients respond well to conservative management. If after successful conservative management, about after 6 to 8 weeks, we'll be performing internal appendectomy in these patients. We have to continue the IV antibiotics for 5 to 7 days, and we can start the patient on oral solid on about 3rd day, and we can discharge the patient at 5th to 7th day. So why do we follow conservative management instead of doing immediate surgery in these patients? The reason being there will be extreme induration and friability of the tissues. All the inflammatory structures will be clumped together. So there will be clumping of these tissues. So it will be very difficult to identify the appendix during surgery. So identification of the appendix is very difficult, and we will not be able to separate the appendix. So separation of appendix from the nearby structures is also difficult. And at last, there is increased risk of fecal fistula if emergency surgery is being performed in these patients. So for these reasons, we do follow the traditional conservative management, but the trends are changing nowadays towards doing or performing emergency laparoscopic appendicectomy in these patients. So after successful conservative management, these patients should be monitored strictly. So when we have to stop the conservative management, criteria for stopping the conservative management is first, if the patient has persistent fever or persistent tachycardia, or if the patient is toxic. Second indication is if the patient is having increasing abdominal pain, or if there is any spread of abdominal pain, as that is mean spreading abdominal pain, which indicates onset of peritonitis. Third, if the patient is having persistent vomiting. Fourth indication, if the patient is having increasing size of the lump. Fifth indication is abscess formation. So in these conditions or situations, we have to stop the conservative management and we have to take up the patient for emergency exploration. So we have to remember two things, that if the patient is clinically deteriorating or if there is any features of peritonitis, it is an indication for early laparotomy. And you have to remember one more thing, if there is any failure of the mass to resolve, so if the mass does not resolve by conservative management, you have to suspect Crohn's disease or malignancy of the cecum. So these things should be kept in mind. So after successful conservative management, there has been difference in opinions among the surgeons whether to do interval appendicectomy or not. So some surgeons prefer doing interval appendicectomy. Some surgeons do not prefer doing interval appendicectomy. So what is the rationale behind these two principles? So first of all, before that you have to remember one thing, the incidence of recurrent appendicitis after an acute attack of appendicitis is being relatively low, which is about 8 to 10%. Even though the incidence of recurrent appendicitis is relatively low, why do surgeons prefer doing internal appendicectomy after successful completion of conservative management? The reason being, first of all, if we do surgery for a patient with recurrent episode of acute appendicitis, the morbidity associated with those surgeries is usually relatively high, which is about 36%. Whereas if we do surgery in a patient without recurrence, the morbidity in those patients is relatively low, 11%. So comparing the difference in morbidity, so surgeons do prefer internal appendicectomy before the patient develops an recurrent episode. Second reason being, there has been incidences of appendicular neoplasm being reported in the histopathological specimen of these patients who are undergoing internal appendicectomy. So not to miss these diagnoses, so not to miss these malignancies, surgeons do prefer performing internal appendicectomy after successful completion of conservative management. At the same time, why do some surgeons do not prefer doing internal appendicectomy after conservative management? The reason being relatively low incidence of recurrent appendicitis, which is about 8 to 10%. And these surgeons recommend doing interval appendicectomy for those two patients. First of all, if the patient develops recurrent attack or recurrent symptoms, if the patient has recurrent symptoms, for those patients they recommend doing interval appendicectomy. Second indication is if there is any appendicolith on CT abdomen, they recommend doing internal appendectomy because appendicolith is associated with increased risk of recurrence. For these two patients only, they recommend doing internal appendectomy. Other than that, they routinely do not do internal appendectomy. So the patients who are not undergoing internal appendectomy should be monitored regularly with CT abdomen and colonoscopy, particularly in patients above 40 years of age. So these patients should be monitored regularly with CT abdomen colonoscopy to rule out Crohn's disease and malignancy, because perforated tumors of the cecum might mimic a perforated appendicitis. So these patients should be regularly monitored with CT abdomen, pelvis and colonoscopy. So the third treatment option available for management of appendicular mass patients is emergency laparoscopic appendectomy. Nowadays, with the advent of laparoscopy, emergency laparoscopic appendectomy is becoming the management option, or it is a good management option for appendicular mass patients. So there has been several studies showing better outcomes with emergency laparoscopic appendectomy compared to the traditional conservative management. So this is a tabular column which shows advantages and disadvantages between the conservative management and emergency surgery. So first of all, we'll see about the advantages of emergency surgery. It is a relatively safe option, it is feasible, and it is also cost effective, and the operative time is acceptable, and there is no need for another admission. And there is no need for internal appendectomy. So by doing emergency surgery, we'll be able to deal with the pathology at the same time, and if there is any unexpected pathology also, we'll be able to deal with it. And there is no need for close follow-up or monitoring of these patients. So these are the advantages of performing emergency surgery. Even though there is disadvantages with emergency surgery, such as it has got a complication rate such as up to 12 to 23%, and the surgery may be very difficult if it is being performed at a later time. Doing surgery, it may be very difficult to differentiate between inflammatory and malignant masses, and if there is any fecal fistula formation, it can lead to ileocecal resection, which is unnecessary, and it usually has a higher complication rate than the internal appendectomy. So these are the advantages and disadvantages of emergency surgery. Even though there are disadvantages with emergency surgery, by laparoscopic appendectomy in an experienced surgeon, it is a good management option for appendicular mass patients. So coming to final summary of management of appendicular mass patients, if a patient with appendicular mass comes to you, so if laparoscopic setting is available and the experienced surgeon confident enough of doing or performing emergency surgery, first management option should be your emergency laparoscopic appendectomy, which is a better management option compared to the conservative management. If laparoscopy is not available, we can do open appendectomy. So alternative management option available is, you can follow conservative management. Traditional conservative management is your ochsner sherren regimen. And you have to monitor the patient, whether the patient is responding or not responding. If the patient does not respond to ochsner sherren regimen, you have to stop the conservative management and you have to do emergency surgery. If the patient responds well to conservative management, you have to continue the conservative management and discharge the patient after 5 to 7 days, and you have to follow up these patients. If the patient develops recurrence, definitely we are going to do interval appendicectomy. If there is no recurrence, here comes the controversy. Some surgeons prefer doing internal appendicectomy, some do not prefer doing internal appendicectomy. The patients who are not undergoing internal appendicectomy should be followed up regularly with CT abdomen and pelvis and colonoscopy, especially in patients above 40 years of age, to rule out Crohn's disease or malignancies. So, so to sum up, emergency laparoscopic appendicectomy is becoming a management option or safe management option for patients with appendicular mass. If emergency laparoscopic appendicectomy becomes the standard treatment option for appendicular mass patients, then the fear of missing or delaying the diagnosis of other pathologies like Crohn's disease or malignancies will be eliminated, as we are dealing with the pathology at the same time. And overall hospital stay of the patient will be reduced and the cost will be reduced, and there will not be any further debate or controversies among the surgeons whether to perform or not internal appendicectomy. So this is all about the appendicular mass. Thank you.